Welcome to Second Opinion, integrating novel approaches into the management of non-muscle invasive and muscle-invasive bladder cancer. This is medical oncologist Dr. Neil Love. On February 26 at the 2026 GU Cancer Symposium in San Francisco, we held a CME meeting moderated by Dr. Terence Friedlander from the Helen Diller Family Comprehensive Cancer Center in San Francisco, and faculty members Dr. Matt Galsky from the Tisch Cancer Institute in New York City, Dr. Andrea Necchi from the IRCCS San Raffaele Hospital in Milan, Italy, and Dr. Shilpa Gupta from the Towson Cancer Institute in Cleveland, Ohio. Included in the meeting were a series of pre-recorded video case presentations by Dr. Elizabeth Plimick from the Fox Chase Cancer Center in Philadelphia, and Professor Thomas Powles from the Barts Cancer Institute in London, who met with me prior to the meeting. These cases were discussed by the faculty panel, beginning with Dr. Plimick. I asked Dr. Plimick to come up with a common clinical scenario to present to the faculty where in the future, or maybe even now, ctDNA may have a useful role.
Here's a scenario of a patient who presents with T4 disease, with pelvic pain and pelvic wall involvement, in addition to maybe a lymph node that's 2 centimeters in the pelvis. You treat them as metastatic initially with EV and P, but after 6 cycles, they have a complete response on their imaging. Is this a patient that you would refer for surgery to consolidate the response? Or is this the patient that we accept as being already metastatic, enjoy the complete response, and hope that that is durable without surgery? It's a tough case. We see that all the time.
Okay, so you have a really challenging case. A patient presents with T4 and N maybe 1 or N2 disease. So this is very locally advanced, very high risk of metastatic disease and ultimately dying of bladder cancer, who starts on EVP, as we're talking about in these different EV304 or EV303 trials, has a really excellent response. So Dr. Gupta, have you had a patient like this who's had a really excellent response to neoadjuvant therapy? And we sort of talked about this before, bladder preservation in this patient. Is there a role for surgery? Would you recommend a cystectomy now and a lymphadenectomy? Or would you kind of monitor this patient and recognizing that some patients will actually, maybe even get cured with upfront immunotherapy plus minus the EV?
Yeah, so this is a locally advanced patient, like you said, and I think patients who achieve a CR really do well long term, and we've seen that follow-up data from EV302. I really don't think that there is a role for consolidative surgery. That whole concept comes from decades ago when we had no systemic therapies which were really reasonable. And I think pushing that in the era of such effective therapies and also effective biomarkers is really an overkill.
Right, so maybe too much, because it is, as we've been saying, surgery is tough for many patients. Dr. Necchi, do you think there's a role for cell-free DNA monitoring here? To consider them sort of having metastatic disease? And I guess what would you do with the cell-free DNA data? If it came back as negative and turned positive, would you do anything different?
Well, if you start from the assumption that surgery has no role, as I would start with, as Shilpa has mentioned, so we don't have any single data suggesting that surgery may play a role in this patient in improving some kind of interim outcomes of survival in this patient population. So if starts from this assumption, then the role of ctDNA would not be so impactful in the decision making as compared to standard imaging tools. So in patients with the CR, when it is slated to continue systemic therapy, I think that there is, as of today, no way of thinking differently with the use of biomarkers. Let's see in the future when we will have possibly newer systemic therapies that can be used in sequence. We can discuss about the opportunity to shift from one treatment to another based on ctDNA positivity or positivization. But as of today, the impact is limited.
Right. I think it's important when we think about cell-free DNA or ctDNA is to think about it as a tool. Right, and you have to use the right tool for the right problem or the right question. And so you can look at it as a prognostic marker to tell you who's going to do poorly, who's going to do well. You could think of it as a predictive marker for who's going to benefit from therapy. And I think Dr. Galsky talked to this a little bit. You could technically use it for discovery to find, other circulating mutations. Do you think, Matt, we're trying to ask too much of cell-free DNA, or are we sort of proceeding in a logical way with this?
I think the right questions are being asked, and it is incredibly helpful to see that studies are being designed to assess clinical utility rather than just relying on retrospective studies for decision making. I think that the field, despite the widespread use, I think in terms of really informing decisions, the field has been pretty thoughtful about trying to design the right studies. I'll say, just as an aside, even though I am strongly in favor of trying to thoughtfully develop approaches that use response in an individual patient to decide whether or not we could de-escalate treatment, there is some correlation between baseline burden of disease and the likelihood of quote-unquote sterilizing disease with systemic therapy. And if there is a window of opportunity for cure, I think it might be with surgery in a patient like this. So I would talk to this patient.
You might push a little harder.
Yeah.
Would anyone push for chemoradiation or radiation alone in a patient like this who's had an excellent response to EVP, perhaps wants to keep their bladder? Recognizing we don't really have data in that context.
And it depends what the bladder is showing. And if it's showing non-muscle invasive disease, I actually have a patient like that, and she's been now disease-free in the metastatic sites for over 4 or 5 years and has NMIBC, and we are tackling that with intravascular.
Right. We have a patient who was on the EV-103 trial who got EVP, had eradication of all the disease, and 3 years later developed an NMIBC, which I think was a new tumor, and actually responded really well to BCG.
Yeah.
So I think there's a lot of different ways we can think about this disease. Okay. And do you think that the ctDNA test in this patient we've been talking about, Matt, that it would change your approach to monitoring? So if they turn positive, you're going to get a scan much quicker, or is there other ways that you're going to use this?
Yeah, I would certainly do scans earlier if this patient had detectable ctDNA. In this context, with regards to the surgical discussion, I would really feel much more comfortable if that patient had undetectable ctDNA before I recommended that they undergo a major surgery.
Yeah. Okay, let's do Dr. Poles again and Dr. Love.
I also asked Professor Powles to describe a case where circulating tumor DNA may have a useful role, and he described a 72-year-old man with muscle-invasive bladder cancer, status post-neoadjuvant chemoimmunotherapy.
He is a patient who has muscle-invasive bladder cancer. He had neoadjuvant chemotherapy with durvalumab because it's pre-EV Pembro era. We used the Natera approach to track his ctDNA. This patient was positive pre-surgery. We gave him treatment. He then remained positive pre-cystectomy. We then performed surgery on him, and we transferred him from being positive to negative post-surgery. He had not had a pathological complete response. But now he's CCA negative. And so my question to the panel with this case is, do you think we should stop therapy, or should we keep going?
Any other questions for the faculty?
I'd like to ask the panel whether or not they feel urinary tumor DNA in parallel with circulating tumor DNA are going to be used together.
I have not heard that one. Urinary ctDNA? Wow.
You could use UTDNA and ctDNA in parallel. And Neil, there was some data from the Sunrise program at ESMO this year that correlated UTDNA with pathological complete response. Almost all patients are UTDNA positive at baseline. And then what essentially happens is there's clearance in about half of those patients with different approaches. And that clearance correlates with pathological complete response. So we're beginning to get a clear signal. And I can tell you at ASCO GU, there are a number of different posters and presentations looking at UTDNA, including one from the Niagara study, which Matt Galsky is also involved with, on UTDNA in the Niagara trial.
Okay, so this is a 72-year-old man who got neoadjuvant chemoimmunotherapy, platinum for durvalumab, was positive with cell-free DNA until after surgery and then was negative, didn't have a complete clinical response. So, I think, Matt, we've already heard you say this a few times that the negative ctDNA result we have to be careful about, whereas a positive one is maybe more actionable. I guess, does that change if somebody's had a complete pathologic response and they're cell-free DNA negative at the time of the post-op visit?
It doesn't, but I think the context is really important, right? So that's a slightly separate question than this patient. This patient didn't clear with systemic therapy, cleared with surgery. I'm really worried this is going to be a very transient clearance, and months later, this patient's going to have a detectable ctDNA. Now, whether or not continuing durva in this setting is going to impact that, it's hard to know, but that's the way that the treatment was given on study, and that's what led to the benefit on study, and so I think it's hard to deviate from that in the absence of data. To your question, if a patient had a path CR in negative ctDNA, obviously, the thought is that maybe that patient doesn't need additional treatment. The problem is that we also don't have that data. And when you look at patients with undetectable ctDNA from Niagara, those patients still benefited from being on the experimental arm. And we don't know if that's driven by the neoadjuvant or the adjuvant portion. But in the absence of the third arm that didn't give the adjuvant portion, that's unanswerable from that trial. So at the present time, in being a purist and sticking to the evidence, you would continue treatment.
Right. So I think what you're pointing out is some of the sort of dissatisfaction with these sandwich approaches, where a lot of therapy is given before and after therapy, before and after surgery, where we don't have a contribution of the components. And so hopefully we'll see that in future studies, but that's going to take a long time. So, I think we've talked about this a lot, cell-free DNA or circulating tumor DNA informing practice. Do you think medical oncologists, and maybe Dr. Necchi, do you think medical oncologists should be ordering this? If this was available in Italy, would you recommend to other oncologists to order this in the perioperative setting?
Well, in principle, knowing that the prognosis of the disease in an optimized way by integrating ctDNA into the tools to which we could assess the patient is good. So first of all, when you start treatment, and you have to inform your counseling with the patient, providing the information on ctDNA, so the possibility to be cured at the end of the day from their disease is important. So it's important for patient counseling. And also, it's important for, as we have discussed, for monitoring of the response to treatment. It's less important, based on the Sunrise 4 data. It's less important if we foresee any opportunity to skip radical cystectomy based on these results. And here it comes the opportunity to integrate with some kind of local assessment, like UTDNA. And UTDNA is pretty well better positioned than ctDNA in predicting the fate of the tumor into the bladder wall. And so for projecting ourselves to the next generation trials and the newer opportunities that maybe result in newer therapies tomorrow, when it comes to the opportunity for the patient to skip radical cystectomy, I would be very much more favorable to pursue this opportunity in patients with ctDNA negative test and the UTDNA negative test.
Great. So it seems like UTDNA, urinary tumor DNA, may have a potential for us to understand how the local disease is being controlled, and circulating tumor DNA may have a potential for the systemic therapy.
Subsequent to the recording of this program, the FDA approved durvalumab in combination with BCG for the treatment of adult patients with BCG-naive, high-risk, non-muscle invasive bladder cancer. The FDA approved pembrolizumab in combination with enfortumab vedotin as neoadjuvant and adjuvant therapy for adults with muscle-invasive bladder cancer undergoing cystectomy. The FDA also approved adjuvant atezolizumab for adult patients with muscle-invasive bladder cancer with MRD-positive ctDNA after cystectomy. Please check out the official prescribing information for more. This concludes our program. Conflict of interest statements for the faculty can be found in the program notes. The use of agents and treatments that are not approved may be discussed, so check out the package inserts for more. Special thanks to the faculty, and thank you for tuning in. This is Dr. Neil Love for Second Opinion, integrating novel approaches into the management of non-muscle invasive and muscle-invasive bladder cancer.